Good afternoon to China, Changzhou Hospital and West China Medical School and Hospital, Huaxi. We are pleased to present to you our live session today in the specialty of orthopedics. We are honored to have Professor Lee here as our speaker from the University of Lincoln, and Professor Lee is both an expert in sports medicine as well as in orthopedic surgery. He will share with us his valuable experiences on total hip joint replacement. Please mute all your microphones as well as your mobile phones for the session. We will ask the questions at the end of the session. Many thanks, Professor Lee. The floor is yours.
Great, thank you very much. So let's begin. Today we're going to talk about hip replacement. Let's go to the slide. So there you go. So I'm Professor Prof Lee, orthopedic surgeon and sport medicine consultant. I work in Lincoln University, and today I'm going to talk about hip replacement. Why are we still using cemented stem? And also, is there any innovation around the hip replacement? Is uncemented hip the best thing? Also, we're going to touch on customized, personalized hip replacement, such as a 3D printed hip replacement. And we're going to touch on a bit on the pathway on hip surgery as well. So before we begin, I got a disclosure to talk about, which is I was the Exeter Fellow, so I was trained in Exeter and learned about the Exeter stem, and also worked in Oswestry, which is in Shropshire, the orthopedic hospital, trained under by Professor James Richardson for uncemented hip. So I got a good view on both cemented and uncemented hips. So just briefly touch on osteoarthritis. On hip osteoarthritis, one of the best treatment options is hip replacement, and it has been termed it is the operation of the century. And I don't really need to dwell too much on this slide about the hip osteoarthritis. But briefly touch on different type of treatment. We got surgical and non-surgical treatment. Recently, there are new devices coming onto the market to help us to do non-surgical management of hip osteoarthritis. This is such as a unloading knee brace, hip brace. Sorry, this is the hip brace here. So the idea of that is to putting some pressure and tension onto this hip and actually bring the hip out and try to change the weight-bearing area on the hip. I have some success with this device, but still it's not as good as a hip replacement. But for the talk today, I'm just going to focus on hip replacement. So there are different types of hip replacement, as we all know. There are cemented hip replacement and there's uncemented hip replacement. So is cemented hip replacement too old? It has been around for a very, very long time. Since Sir John Chanley, they have discovered the hip replacement and invented the hip replacement. Things have evolved since. So on the screen here on the left, this is the very popular hip replacement in Europe. And this is the SP2, the Link SP2 Labinas. Have great clinical results. And the photos in the middle is the Chinese hip, and you can see the evolution of the Chinese hip. And then at the end, you can see the great Exeter hip. Now, these are the cemented hip replacement. You may see that, oh, this is been around for a long time, and is it actually technology and move on without them? Well, we talk a little bit about that later, but these are essentially usually the cemented hip that we get exposed to and we use to. And then let's talk about uncemented hip. Is uncemented hips an innovation? Like what the companies say. You can see there's different type of uncemented hip. You get diaphyseal loading, you get proximal loading, you get fully coated, partially coated, you get ingrowth, on growth, all sorts of different terminology that you can get on uncemented hips. But essentially is about how the bone grown onto the prosthesis, and that's what the uncemented hips do. Now, let's just park that for a second. Then we look at the literature to see is cemented hips better or uncemented hip better before we go on further to talk about different philosophy between these hips. So this is a very interesting paper that I found online from the Clinical Orthopedic Related Research by Henrik Malkow. It's a very, very good paper looking at the different registry in the world about arthroplasty of the hip, the cemented and uncemented hip. He compared between them, between all the registry. So he had reviewed 27 different countries that is supplied into the ephod, and then these are the countries that we looked at. So there's some very interesting facts here. You can see there's different lines here. These are talking about the percentage of uncemented hip use in primary hip replacement. And you can see the lines here. The top line here is Canada. So in the Canada, North American, they tend to use a lot more uncemented hip. And then as we go down the line, you can see Denmark, Australia, and then New Zealand, and then the next line is the UK. So that is back in 2010, but by now we're about 50-50. Unfortunately, the cemented hip have dropped and the uncemented hip have gone up. And you can see this is the Scandinavian country, the Norway and Sweden. They have actually been staying with the cemented hips. Is also a slight increase. So let's have a roll. So furthermore, they look into more detail into four countries that got the actual registry, compare cemented, uncemented, and hybrid total hip replacement. So these are the four countries that we compared. So that's Australia, Denmark, UK, as well as New Zealand. So these slides are very, very interesting. I got two of these slides, and I'm going to go through them with you bit by bit. So you can see the difference between you can see the colors in these boxes here. If there is a difference, it will either be a red or be green. If cemented hip replacement is worse, they have a worse outcome according to history, it will show as red. If the cemented hip replacement have a better outcome than the other one that we're comparing to, it will show green. And if there's statistically insignificant, no difference between them, it will show yellow. So these are very important keys that we need to remember. So first of all, we look at over the four country. For somebody that is age under 55 years old, there is no significant difference between cemented and uncemented hip. The only registry show uncemented hip is better than cemented hip is the New Zealand registry. So you can see, looking around the world, there's no difference, but only a small registry in New Zealand show that. So when we look at slightly older people between age 55 to age 65, and you can see there's a bit more of a difference shown here. In Australia, in Denmark, it's shown that the uncemented hip is better than cemented hip, but bear in mind the popularity and they tend to do more uncemented hips anyways in those two countries. And if you look at England and Wales, which tend to do 50-50, we actually have shown that cemented hips in this age group is better than uncemented hip. In male and in female, there's no difference. And surprisingly, interestingly, in New Zealand, there's no difference between cemented and uncemented hips in that age group. And furthermore, the more important part is the patient that's over 60 or over 65. Which hip is better? Is it cemented or is it uncemented? As you can see down here, mostly it's green, which means that cemented hip completely outperform the uncemented hips. And with one exception, which is here with Australia, and I think that is probably due to the amount of hips that they do in there, which is a lot more uncemented. But overwhelmingly in the other registry, all showing that anybody over the age of 65, really cemented hip is the way forward. Now you may argue that what's the difference between some how about hybrid? What do we think about cemented hip versus hybrid? If it's just the cup, what do we think? So this is the next slide that I want to show you between the cemented hip versus hybrid hip replacement. And on this slide, again, is a similar principle. The first bit is age under 55 or age under 50. The only registry show that hybrid hip is better is New Zealand. The other registry show no significant difference between a cemented hip or hybrid hip. And the next slide here is after the age group of 55 between 55 and 65, and within this age group, again, you can see there's two countries that show that hybrid hip is better than cemented hip. So these are Australia and New Zealand. And the all important bit at the back, at the bottom here, that the patient that's over 65, which tend to be the vast majority of what we operate on these days, you can see it's green everywhere. Pretty much the cemented hip is outperformed the hybrid hips, or the only one within this within these 8 squares, the only boxes that is red is in Australia. That is for patients between 65 to 75 years old. And that they showed us the hybrid hip is better than cemented hips. So it is safe for us to give a conclusion that the revision risk is statistically lower when we use cement. So for patients that is over 65, and this is hence is the paper of the uncemented paradox. For some interesting reason, the uncemented hip has climbed over the years, and I think that is keep on climbing. But we just need to be vigilant and understand the evidence and why we're doing what and what actually give us a good outcome. So after we review all this evidence, these are my choice for my hip replacement for a patient that I do hip replacement on. These are the standard that I use usually, unless there is some very, very interesting pathology, then we will consider using different type of stem, perhaps an uncemented stem sometimes. But usually, in the general rule of thumb for me, patients aged between 18 to 60, I would try to use a hybrid hip replacement, a uncemented shell at the top, and for the cup, for the acetabulum, and I will use a cemented excessive stem for the femur. And anybody above the age of 60, I will use a cemented hip, cemented at the top and the bottom. Let's go back to the beginning when we talk about different type of fixation into the hips, and there are the logics between the stem, the design of the implant. So first of all, we want to look at the uncemented implant. So the principle of that is whether that is a very rough surface, a coated surface, or different chemical people can put onto the surface or the metal. The idea is to get the bone ingrowth onto the metal and grab onto it. And the idea of that is you would rely on the body biology to grow into the bone. Now, as we know, as orthopedic surgeon, we know that one orthopedic unit is about 6 weeks. So usually you would expect take about 6 weeks for the bone to ingrow onto the implant, which is fairly reasonable. But therefore, some surgeons would partial way bear the patient for a little while before, so helping the bone to grow onto the implant until it's solidly completely fixed is one of the view that people think about. Alternatively, we're talking about the cemented stem. With the cemented stem, what they call osteointegration, the bone cement interface is already present at the moment that we put the stem in. We pressurize the cement, and when the cement sets, this is settled, and the stem will sink slightly over the time, but we are measuring that in micrometers. They are very, very small. The moment that it will keep on sliding down, and it will create further pressure around the femur, which will then further load the femur. The difference between a cemented and uncemented implant is, for me, the difference is osteointegration. We achieve osteointegration with a cemented implant immediately, and with a uncemented implant, we will have to wait for 6 weeks, approximately. So this is something worth thinking about. Do we want something that we can control, or do we want something that we would need to rely on the patient's biology? And next thing for me is about infection. A hip replacement is a large chunk of metal that we put into a body and even into the bone. With this huge, big metal, the only possibility of long-term risk is infection and wear. where we can do some, we have new technology, we can talk about the bearing surface, we can use about different bearing that can be taken care of and reduce the amount of wear. However, infection is a very important thing that we need to think about. So to me, with a big metal implant, I would like to wrap it around with antibiotics. There's only one thing that we know on earth that can kill bacteria is antibiotics. So this is one of the reasons that why I like to choose to use a cemented implant, because with a cement, I can load a lot of antibiotics around my stem, which will give me the security of reduce the chance for infection. That's just my own personal view, and as you can see on this diagram here, that biofilm can form very quickly. When you only need a few bacteria land into a surface, and over time, within hours, they can start multiplying, and they will form biofilm, and then these once the biofilm is formed, these infection is there to stay. So for me, it's very important to have antibiotics right at the outset, right next to the implant. So you may ask, for the age 18 to 60, why do I use a hybrid hip replacement instead of a fully uncemented hip replacement? I think the difference really to me is the stem. The stem on the femur side, and if I use a Exeter hip, it will give me a ease of revision. And if I want if we operate on somebody who's 18 years old, there will be no doubt in their lifetime we will have to do a revision, 1 or 2 revision for them. The difference between if we have to remove the stem for any number of reasons, whether the head-neck junction have changed, the company gone bust, that we have to change a different head, or we have to change a version due to dislocation, due to wear, or we have to take the stem out for ease of access to perform the revision surgery. I think I would much prefer to just tap out an Exeter quickly than cut the whole uncemented stem in. I think this is something that we need to think about revision surgery. Antibiotics, I have talked about. We want to wrap the stem around with very highly loaded antibiotic cement. And the very, very important point for me is, I know we need to get it right for every single patient, regardless anyways, but I think for these young patients, we need to really get it perfect. So by using a cemented stem, a taper slip stem, I would be able to control my version and my anti-version completely with a complete freedom. We can change it from -20 to +80 if we really wanted to. And also, to me, a cemented taper slip stem is a custom stem, because I will be able to get my leg length, the offset right every single time with the combination of the angle that we provide within the cemented Exeter stem. For the cup, I would like to use a uncemented cup for this younger age group. Why? The reason is because of the data, because of what I showed you earlier on, and also looking at the registry, which I show you on the next slide. It has shown that because due to the torsional force within the pelvis instead of the compressive force on the femur, there is evidence to show that the uncemented shells can perform better than a cemented shell. And when I do a uncemented cup, I would tend to use a primary press fit. I don't try to use any screws if I can help it on a young patient, and I will cover all the holes. The reason is twofold. One is infection. If by chance that they have an infection, these pus will leak through the holes and create the pressure and go up to the pelvis. So therefore, I already close all those holes, and also will make revision much easier. We don't have to think about taking the screws out. We can just use a explant to remove the shell if we absolutely have to. And by definition, young people between the age 18 to 60 would have good solid bone. So therefore, I think the press fit philosophy works very well in this group. Now let's look at some more data. This graph is from the National Joint Registry from the UK. This is recently published, so it's 2018. So this is the 15th registry. So these are the different lines talk about cumulative revision risks. So you can see it down here, and on the axis down here, the x-axis is actually talk about the year since we first implant surgery. So if you can see, if you're using a cemented hip, you can see the line is up to here, and then if you compare the uncemented hips, there's a blue line, which is very, very similar anyways. And then if we talk about hybrid, it's clearly the revision risk is lower compared to the cemented and uncemented hips. And you may wonder what this line is. This is the metal hips. And this line here is reverse hybrid, which is something that we don't really use. And so here we go. This is I'm just going to say a few words about the Exeter stem. It is designed by Professor Robin Lings in 1970, and since then on, there has been many evolution and innovation over the last 48 years, and it's performing really well. And now instead of one stem, we have almost 27 stems in the armamentarium. Within that, we will be able to get our offsets correct. We will be able to get our leg length correct. Also, we can get the size of the stem and fit into the femoral canals much better. Also, there are many different techniques in terms of how we can restore this femur, and in terms of we can save bone instead of take away bones. So this is earlier I'll talk about the bone cement interface, the osseointegration. So you can see this is the cross section of a femur, and this is bone and that's cement. You can see it's completely integrated in the moment that the cement is set. So in my books, why should we wait for 6 weeks for osseointegration, where it's something that we can achieve immediately on table with the patient? The next thing, after I talk about the cemented and uncemented stem, then I want to talk about the surgical technique. Traditionally, there are many different techniques. There are in the UK, the common technique is a lateral hardage type approach or a posterior approach. Of course, there are other approaches such as anterior approach, and also the superpath approaches gaining popularity slowly. For me, I use the posterior approach because I think it's an extensive approach, and I would like to protect the gluteal medius muscle. Furthermore, now we have used this newer technique, which is a minimal invasive posterior approach. Now, the minimal invasive sense is not about the skin minimal invasive, it's about releasing less tendon. So SPARE is stand for saving piriformis and internus and repair externus muscle. So let me show you a few diagrams about the attachment of the external rotators at the back. So looking at this slide here on the left, we can see this is where the gluteal medius attach, and where the P here is where the piriformis attach, and then where the star is where the obturator internus attach to the bone. So you can see they all have separate attachment, and the really interesting side is here on the right here. You can see this is obturator externus. So obturator externus is completely separate to these the piriformis and internus. The attachment is very different, and we can see that if we release this tendon, we've got a window from here to here, be able to take the hips out through that window. And that is what a SPARE approach about. So here is a intraoperative photos. So this is a posterior approach, patient on the lateral decubitus position, and this is operating on the left hip. And we can see this is the femur, which I can show some diagram at the bottom, which is the same thing, we just label it. And then this is the gluteal medius, and then in here, this is the piriformis. And this is where is a QC is the quadriceps coxa, which we grouped the glomeruli as well as the obturator internus into this group, and obturator externus and the quadriceps femoris is here in this windows here. Of course, the sciatic nerves is always go down there, so we have to be careful. So this is the interval that we go with the SPARE approach and you can see after we do this approach, when the hip was gone in, this here, the obturator internus muscle, the quadriceps coxa, it acts as a check rein. It's a biological check rein to stop the hip dislocating. And it's very clear that when we have done the surgery, it really stopped the hip pushing out posteriorly. So then after we talk about techniques, I want to talk to you about innovation. What sort of innovation is coming along in hip surgery? So you may have heard of robotics and you may have heard of custom guides. This is something that I think the company are pushing very hard on in the moment. And first of all, let's quickly talk about robotics. I'm sure robotics have its role, and robotics nowadays is actually we'll be able to place our cup or our in a very, very accurate position. But my biggest question is, do we actually know where we should put this cup? Is 45 degrees or 40 degrees or 20 degrees of version in antiversion will make, is it the right position for that patient? Is every patient the same? How are we going to judge that? I think a robot is very useful and it can help us to put it into a good position, but I think more important question is where we need to put it and how we can customize it and tailor fit for that patient. Again, which is similar to some of these guides that we produce on the right hand side here. These are the custom specific jigs that we can help you to ream, help you to cut the neck, and to help you to put the hip in the right location. However, again, we have the same problem. We may base things on CT scan, we may base things on the computer, but actually, is that where we want it to be? So therefore, I would like to take you over to this slide, which is more important. I think that we need to think about the angle between the pelvis as well as the hip, because the hip is joined to the spine via the pelvis. It depends how stiff between the pelvis and the spine is. The movement of the hip and the hip socket really depends on how flexible this part is. If the patient is a lot more stiff, you may want to put the angle in slightly different to someone that is completely flexible. And I think this is something that there's work's been done on it currently, and there are some devices out there that we can measure and actually take these into account when the patient is sitting, patient is standing, and I think that will really give us a true functional anatomy and a true functional position of where we put our cups. And of course, after we determine that, the robot becomes very handy. So next thing I want to talk about is other innovations such as hip resurfacing. Hip resurfacing in the UK has come and then has gone and then now it's come back again, which is very interesting. Now there are different schools of thought on the hip resurfacing, and I think hip resurfacing is extremely useful and a very, very good operation for the right patient. And now, if you read any literature or any advertising marketing material, they will tell you who these guys are. Usually, are very, very large male with big hips that they tend to do well. Now, I just want you to think about and remember what happened with the metal on metal problem, and hip resurfacing is metal on metal. Now, I think latest, and there are something coming along, is the ceramic on ceramic hip resurfacing, which is coming on the market. Perhaps it is a very good step forward, maybe or maybe not. This is something that I think we need to watch carefully, and I think potentially once we have good evidence that show that it works well, it may be a subspecial group that we can use it. And don't forget, hip replacement already performing really well. So is that really a great role for this type of surgery? I would like you to have a little think. And the next thing about a possible innovation is this mini hip, so a proximal loading small stem. The idea from, I presume the company would say that, yeah, it will help you to preserve bone and it will make life easier when you do a revision. Or perhaps, it is more anatomical, you don't have to change the version, and it is got very good result. I agree to some, into a certain extent. I used them before and I published on them, and they are very easy to put in, very nice to, a very sexy looking hip replacement. However, I would like you to think about, if you have to remove this hip as a revision, what would you need to do? You will still need to cut between, because this is a uncemented device, we need to still cut between the bone implant interface, and that potentially can cause problems. Think about if I have put, if I just simply use an Exeter hip and I just need to burr that little bit of cement off the shoulder and the stem just tapped out, make my revision much easier. I think these mini stem, small stem do have a role, but I think we need to be very careful and select our patient very carefully. And the other thing I want to talk about, you can see the last 3 slides, most of my bearing surface is ceramic on ceramic. Ceramic on ceramic is okay. I think a few years back, people think that is the best bearing surface. However, like any hard on hard bearing surface, it does have its problems. So you can see it is less forgiving, and if there is any edge loading, it will cause problem. And sometimes the metal neck can impinge, and it can also cause problem. And you can see over the last, this is again from the National Joint Registry, over the last few years, things have changed. I would like to draw your attention to the gray arrow here. The gray arrow here is this line here. The gray line here is the bearing surface used in the UK. So that's ceramic on ceramic. It has gone up to 2011, and then since then, it's dropped rapidly. That in 2017, less than 20% of people using ceramic on ceramic. I think it's going to be less and less and less. If you look at the orange arrow here, which show metal or metal hip replacement, and you can see again it was a great hype, bring it up to high to 2007, and suddenly it's a big drop. Hard on hard bearing surface is not something that we tend to use in the UK anymore. And you can see the bit that really are going up is the blue line here, which is the ceramic on polyethylene. The problem about ceramic on ceramic bearing surface is that it can make a noise. They do squeak. It's up to 40%. There's been reported in literature up to 40% people will complain of squeaking. Of course, it depends what paper that you read. Now, if this hips are squeaking, there's absolutely nothing as a surgeon you can do about it beside a revision and change of liner. Now, it is not that convenient for a patient. So it is something that we try not to use anymore, and we try to use ceramic on poly, so hard on soft bearing, for the younger patient. And for the older patient, polyethylene on metal would perform extremely well also. And we did say we're going to talk about 3D printing. And 3D printing, we can got some very, very beautiful hip that will fit perfectly into someone's pelvis, and we print out and sort out all the bone defect, and you can see all the beautiful trabeculae that we will imagine all these bone will grow onto the surface, and you got holes there you can put screws in to fix that very well. I think it is something that it is a very useful technique in some patients. I do not think that's something that we should use routinely. Let's not forget, there are techniques out there that has been used by surgeons for a very long period of time and have majorly great results. You can see the X-ray down here, with cages, mesh, impaction, bone grafting, and cement. It really make a big difference. And we can actually, if you talk about, about this, where to put the position, where we put this implant, who really is in charge, on the 3D printing side, surgeon is not the person that is drawing this drawing, and it's the engineers, is the people that in a dark room in front of the computer. So these are the people really are the person that in charge of where we're going to, where this cup is going to sit, of course, based on some CT. But again, when things go wrong, who are we blaming? Is it a group of people that in front of a computer that's trying to draw this? Or on the other hand, if you look at the traditional technique that we use cement, we use cages, and then this is actually a custom fit. And who is in charge at that point? The surgeons will be in charge based on years of experience. I do, want you to think about what is the best way forward in dealing with these big defects. And finally, just going to talk about the pathway of hip replacement within the every surgery. It is very different, and I think hip replacement, we can talk about the shiny new implant and different bearing surface, about how changing this cemented versus uncemented, we got 5% benefit of 20 years follow-up result. All these are very good and very interesting to talk about. But however, the more important part that we can make more of a difference is the other non-surgical side, which starting from the consent process, the prehabilitation process, all the way down to post-op discharge and physiotherapy. And do you, and different type of sutures that you can use, and also do you use cooling and all sort of things that we can think about in terms of surgical technique. And I think this is very important. In the future, we should focus more on the pathway and how we can actually achieve great results for every patient. So in summary, for me in the future, I would talk about, I think I will continue to use spare approach for my hips, and I will use hybrid hips for most of my younger patients. And we need to look into functional positioning. I think these are the future, and also we need to develop a better pathway for our patient. And once we develop that, we can continue to improve it. And by doing that, I think we will get more gain than actually playing with the implant. So here is my summary. Thank you.
Thank you very much, Professor Lee, for this incredibly presented overview of hip replacements. I just have a quick question before we open the audience. Does the uncemented hip lead to a longer rehab stay in hospital if they're only partially weight-bearing then? How does that affect the hospital costs?
I think it depends on surgeon to surgeon, hospital to hospital. Some surgeon would say that you must not partially weight bear for 6 weeks, and they will give patients crutches, 2 crutches to walk on. And some centers, some patient, some hospital may say, no, you just walk on it. It doesn't really matter. So I really think it depends on what type of implant that you use. And potentially, yes, if the patient cannot use their crutches very well, they might have to stay in hospital for a bit longer. But again, I think there's other factors in play here too.
Yes, thank you very much. Let's move to Changzhou Hospital's audience and ask if we get any questions from the audience in Changzhou. Good afternoon, Changzhou. I've unmuted the microphone. Can you please signal if you have questions?
Prof Lee, I would ask one question. In your opinion, what are the most common complications of cemented TSA, and how to prevent it? Thank you.
Sorry, what is the most common? What did you say? Sorry, can you repeat the question again? The mic wasn't very clear.
What is the most common complications of cemented TSA? In hospital.
Sorry, there's a lot of echo there. Can you, Lee, can you tell me what is the question?
Let me just try to ask for a message question then. Your microphone, Changzhou, your microphone has a lot of echo. Can you try another one perhaps, the first step, and otherwise we send a message.
In your opinion, what is the most common complications after cemented TSA?
Complication, yeah.
And how to prevent it?
Okay. The most common complication of cemented hip replacement, is that right? Is that the question?
Yes. Yes.
Okay. So the one of the common complication of cemented hip replacement is fat embolism, because we really wash the canal when we are entering the canal. We actually open up the fat. One of the best way to prevent a fat embolism within the canal is to wash that canal before we actually put any instrument down. So one of the techniques that I use is when we have started, when we're starting on the femur, before we even put the pencil reamer down to open up the canal, we will use the pulpus lavage in there and suction to clean out all the fat. And you can see a big, quite a significant amount of fat will flow back into the canal, and that can be sucked away. And I think if you do that on every single case, you will significantly reduce the fat embolism. And some people actually call that this is the cemented disease. But if you really look at the transthoracic echo, it does not show cement going through the the heart. Actually, what has gone through is the fat. But that is a very, very important thing we must do every time we do a cemented stent, is clean the canal properly with pulse lavage and to reduce the complications.
Thank you for your answer.
Any other questions from Changzhou Hospital? Maybe we should also ask back, what is your preferred procedure at the moment for hip replacement? Maybe somebody could comment on this.
Dear Professor Lee, In my opinion, most of your patients is cement this. How do you prevent the bone cement implantation syndrome and your treatment? Thank you.
The cement implantation syndrome. So I think it is something that we will talk about. You must give proper wash into the canal, and really when they talk about a cement implantation syndrome, is pushing those fats in the bone marrow into the blood, and that's what's causing the problem. It's not the cement itself caused the problem within the body, and mostly it's a shower of this fat, and that's clogging the lungs up, and that's what's causing the problem. And by washing it, as I said earlier on, could really prevent that.
We're getting some more questions. Go ahead.
Yeah. Professor Lee, thank you for your presentation. And I have a question for you. I noticed that you say the age is a very important factor when we choose the cement and the cementless processes. And I want to know, is there any other factors we should consider when we choose the processes when we do the THA, like maybe the activity, and other things? Thank you.
So your question is about instead of age, we can look at what activity they do. Is that correct? Is that what you're trying to ask me? Do we base our treatment on the activities? Of course, I think it's very, very important. It depends what the patients do, and that's when I talk about the functional hip positioning. Obviously you need to use a different approach and different sort of technique when you're treating somebody that is walking on a walking stick, or someone that got Parkinson's disease, or someone that actually is very active, is a fireman or a climber. And again, I think another very important thing we look at is, like any arthroplasty surgery, is the joint above and the joint below. And in terms of the joint above for the hip is the pelvis and the spine. So we want to see how stiff it is. Have patient had fusion at the back before, and if they have, things do change. Sometimes we want to take a sitting and standing X-ray to look at the angle of the pelvis, and by doing that we can work out the inclination of the cup position. I think that's very important. And also for a more active patient, I tend not to use ceramic on those patients, because I worry that if they fall, the ceramic will fracture, and if the ceramic fracture, that can cause all sorts of problems. At this age group, I would want to use a ceramic metal. So one of the bearing circuits that I use is the black the ceramicized metal, so which is something that can give the smoothness, give the wear rate of a ceramic, but at the same time it's as strong as metal. So for some of the young active people, that's why it's leaning towards. But otherwise, usually, relatively standard is the ceramic, and then slightly older, then we will use metal.
Okay, thank you. I have another question. You said that we have advantage when we doing the revision for the cement process for the femur side, but we have encountered some difficulties in our hospital when we doing revision for the cement femur processes. What techniques will you recommend us for us to use when we should remove the cement from the femoral side? Thank you.
Okay, so removal of cemented femoral side, there are many different toys and different techniques out there. What my favorite tools is the Seabatom. Basically, it is a very, very high-speed burr. We can burr that cement away, and that's the best tools that we use. There is Oscar, but I don't tend to use the Oscar, because what that happens is it tends to melt the cement, and it takes a long time to scoop them all out. The best tool is a very, very high-speed burr with very big torque. They use that type of burr in neurosurgery to make burr hole for the bone, but that's the best tools that we have used. And also, don't forget, if you're doing a cement on cement revision, you do not have to take all the cement out. You only need to take a little bit of cement at the top and depends what it is, of course, and to tap the stem out. If it's for infection, again, you do not have to even for infection, you don't have to remove all the cement. It is enough for you to remove some of the cement to create a fresh surface and re-cement a very, very high load antibiotic cement into it.
Thank you.
有什么需要跟他探讨的吗？是不是？别客气。
Dear Professor Lee, thank you for your nice talk. I wonder that would you mind to provide your percentage of the revision in your cases which underwent the cemented local tapes arthritis. The major in our hospital we prefer to use the augmented tapes. The major concern, one of the major concerns is that the revision. So we have found we are care about the percentage of the revision in your cases. Thank you.
I think your question is about the difference about uncemented. You say the uncemented hip doing quite well as well as the cemented hip. I totally agree with you. It is true. It's not much difference. It is not much to it between cemented and cemented hips. But in my, this is why I go on and explain the different logic that I have between why do I want to use why do I not want to use a uncemented hips? Because revision is something that whether we like it or not, it will happen. If you're doing a hip replacement on somebody who's 18 years old, you will have to revise it. Whether that is 1 year, 20 years, 40 years, that will have to happen. Infection is something that you cannot control. If you have an infection in that hip, you will have to take all the metal work out, and if you have to, it is a big difference by taking out a cemented hip and uncemented hip. The time difference, the amount of blood loss is very, very different. I know it's a little bit quicker in surgery to use a uncemented stem. You just put it in and it's press fit and it's done. Yep, it's 10 minutes faster, 20 minutes faster. But at the end, when you have to go back to revision, it's about 3 or 4 hours longer. When you have to, cut that stem out, maybe you have to do an extended trochanteric osteotomy and then wire it back. The blood loss is significant. And also, if you do a extended trochanteric osteotomy, the rate of dislocation and complication is much, much higher. So, if you want to think about your patient, I think it doesn't make any logical sense, unless, of course, you got some very interesting anatomy that you want to, change the version completely, and at that moment in time, a cemented hip may be better.
Thank you very much.
Okay.
还有问题吗？护理的头从这来。
Professor Lee, I have another question for you. I noticed you said that the hip joint is a joint of the spine, and when we're doing the PHA for the AS patients, the ankylosing spondylitis patients, should we acquire or get more version angle when we put in the acetabular components process?
I think that's a very interesting question. I think that the real answer is depends on the patient, and it depends on the anatomy, and also depends on what they do. The biggest problem is if you look at a young patient, if they have arthritis, you may ask why do they have arthritis. So their native version or anti-version is not going to be right, because that's what leads to arthritis. If you put the hip back into that exact position, these hip will wear. Instead of having arthritis, they just wear out, which is not good. So therefore, these are the ones that you really want to change the version quite a lot. But again, how much and what I think it depends on which patient that you're operating on, and where these functional X-ray become really important to us to plan where we can put that joint. And let's not forget the version of the cup and the version of the femur is independent, but at the end it's a combined version that make the biggest difference. And if the acetabulum is put usually, you know, the 40 degrees and 20 degrees of version, that would be okay. And I think that's reasonable for most cases. But for some of the more complex or for some of the younger patients, I think we need to think of it a little bit more. In terms of the version of the stem, it depends on what approach that do you use. Some people, when they do superior lateral approach, they tend to put the stem in neutral, or they tend to put the stem in slightly, ever so slightly retroverted, because of fear of the patient. I'm not sure that's a good way to do things. Hence, I don't tend to use the lateral approach. I use the posterior approach, and I tend to put them into the 20 degrees of version. But then it depends on the patient.
Thank you.
Okay. Professor Lee, that's all today. Okay.
Thank you.
Thank you very much, General Hospital. You have been a very wonderful audience, asking very interesting questions. I understand that the Huaxi Hospital doesn't have a question for now. May I just double check, Huaxi? Can you please confirm if you have questions or not?
No problem.
No questions. Okay, thank you very much, Huaxi. So I believe that we can conclude the session. It was a lot of food for thought presented today by Professor Lee, making us think twice. When do we decide for cemented versus uncemented replacement, and bringing in very valid considerations why we should look into the future when we are deciding on the present. So many thanks, Professor Lee, for your excellent presentation, and I hope we will catch up again for the next session.
Thank you. Thank you very much.
Thanks a lot, everybody. Goodbye from UKmed, and have a nice day.